Cardiovascular system. Auscultation. Technique. The evaluation of the cardiovascular system includes a thorough medical history, a detailed examination of the heart and the peripheral, arterial, and venous circulations, and appropriate laboratory studies. A careful assessment will enable the examiner to identify the etiologic, anatomic, and physiologic components of a specific cardiovascular disorder, as well as to determine overall cardiac function. The examination involves inspection, palpation, and auscultation of the heart and vessels. Proper use of a quality stethoscope is essential during auscultation. A diaphragm pressed firmly on the chest filters out low-frequency vibrations and amplifies high-frequency vibrations. It is routinely used to hear the first and second heart sounds, systolic murmurs, and the diastolic murmur of aortic regurgitation. The belt should be applied to the chest with very light pressure, barely creating an air seal, so low-frequency sounds and murmurs are appreciated. It is used to hear the third and fourth heart sounds and the diastolic murmur of mitral stenosis. Procedure. Introduce yourself and confirm the patient's identity. Ask for the patient's consent before beginning. Ask the patient to remain in lie supine. Raise the head of the bed 30 to 45 degrees. Expose the chest before starting. The normal first heart sound S1 is audible in each of the 4 classic listening areas, though its intensity and quality will usually differ in each of the 4 main auscultatory areas. Start with the aortic area. At the right second intercostal space, listen for normal heart sounds, other sounds and murmurs such as the aortic ejection sound and the murmurs of aortic stenosis and aortic regurgitation with the stethoscope diaphragm. Second heart sound S2 is best heard in this area than S1. Move the diaphragm to the left second and third intercostal space to listen to the aortic and pulmonary components of S2, the pulmonary ejection sound, and the murmurs of pulmonary and aortic regurgitation. Move down to the tricuspid area along the left sternal border at the left fourth and fifth intercostal space. Listen for the murmurs of tricuspid regurgitation and tricuspid stenosis and the murmur produced by ventricular septal defect. Right ventriculars S3 and S4 sounds, gallops, can be best heard in this area with the bell. Here the splitting of the first heart sound is best evaluated. Then move towards mitral area at 5th intercostal space at the mid-clavicular line, an aortic ejection sound, a mid to late systolic click, the opening snap of mitral stenosis, the systolic murmur of mitral regurgitation, and occasionally the high-pitched murmur of aortic regurgitation are also heard in this area with the diaphragm. The heart sounds are usually loud at the apex because the heart is in direct contact with the anterior wall of the thorax. S1 has a booming quality and is lower pitched, duller, and longer than S2 heart sound. S1 is usually louder at the apex than S2. A loud S1 is a classical finding of mitral stenosis. To listen for the third heart sound, turn the supine patient to a 30-degree left lateral position with the left arm extended upward away from the chest and the weight comfortably supported by the left hip, lateral chest and left arm. Palpate for the apex beat while listening with the bell of the stethoscope applied near the apex. Children, young adults and pregnant women may have a normal third heart sound. Listen for the fourth S4 heart sound. S4 is best heard with the bell of the stethoscope placed lightly over the apex, barely making an air seal, and is attenuated with increased pressure on the bell, that is, Creation of a diaphragm. S4 is normally not heard in healthy individuals. It is important to auscultate all these areas with the bell of the stethoscope. Auscultation should also be performed in the sitting position since the heart sounds may be distant or even absent in the supine position. To listen for venous hums, move the bell of the stethoscope to the medial end of the clavicle and the anterior border of the sternocleidomastoid muscle. Turn the patient's head away from the area of auscultation and press firmly to listen for a continuous low-pitched sound during ventricular diastole. Physical findings must be interpreted in light of all previously collected data. The general scheme is to develop a postulate and test it with further history, additional observations or maneuvers on physical examinations, and laboratory tests.